Hello,
Hello, everyone.
everyone.
Good morning.
Good morning. You're in the right place if you're here to learn how to implement point of care ultrasound successfully, specifically focusing today on primary care and urgent care practices. So we're just going to give people a few more minutes to join, maybe 2 minutes. It seems like there are some people in the waiting room still. Thanks for being here. I am joining from New York City. So if you want to drop in the chat where you are based, that would be great. Oh, I got Ketchikan. Wow. Welcome. Nebraska, Georgia. Oh my goodness. All over the place. Wyoming, California, Chico, Toronto. All right. Well, I really appreciate you all being here, and I'm going to go ahead and get started. Um, Welcome. My name is Dr. Tatiana Haberlok. I'm an emergency physician and founder of Hello Sono. I've been using clinically for emergency departments in New York City to Everest Base Camp. And I really see the value of this tool. So I've been on the mission of bringing this tool into primary care space, rural space, and also in urgent care to really benefit patients from POCUS in a high quality and safe way. I also, before I forget, I do want to introduce you to Pia De Jesus. She is supporting this webinar. So if you have any questions you wanted to ask in private, you can just shoot them to her, and she can post them later during the Q&A session. And please keep yourself muted for the majority of that webinar, and at the end, you'll have an opportunity to unmute yourself and ask questions or just drop the questions in the messages. And a little bit more about myself. Well, I forgot to tell you, I am based in New York, and I traded Mount Sinai for emergency residency and for fellowship, and was a ultrasound director at the Brooklyn Hospital in the emergency department. So all of those skills that I learned working in these academic centers and supporting residency programs, I am bringing to the outpatient space. And I'm so happy to share everything I learned with you. A little bit more about me. This is me performing ultrasound at 17,000 feet on a glacier at Everest Base Camp in Nepal. And if we could do that there, you for certainly can do this in your clinic. These are my two awesome cats, Hunter and Sage. And if you have met me at any of the conferences, you know I'm a bit of a obsessed with pickleball. So I'd be happy to meet you on the court. And now that you know a bit about myself, we have two polls for you just to learn a little bit about you, who's in the audience. So, Pia, if you could just bring up our polls, that would be great.
Yes, it's up.
So, are you a clinician? If so, what type of practice are you in? Or maybe you're an administrator, or maybe you're both. We'd love to see who's here today. All right, we have mostly, it seems like urgent care is representing the most, followed by primary care and emergency and other. And our second question is around billing, and if you are already performing POCUS. So it seems like no one is actually performing it and billing for it, but some are using POCUS for clinical decision making. Um, Most of you are not, though, using POCUS. So you are in the right place to learn how you can introduce POCUS into your practice. And Pia, would you mind just sharing the results with everyone?
Okay.
Thank you. Here we go. And our next poll is really about why you're looking into point of care ultrasound. And you can choose as many as you want, maybe choose your top 3 reasons. Um, is it because you want to be on the cutting edge of medicine? Is it because you are having shortages with your red tech staff, or just really difficult to get imaging for your patients? Maybe it's improving efficiency. We'd love to learn more about why you're here. We're having quite a few people answering that improving diagnostic accuracy and confidence. For sure, POCUS is really great at that. Enhancing patient experience. There's actually research on this. Patients love getting POCUS. Um, and staying on the cutting edge of medicine, that seems to be the top three. Pia, would you mind sharing the results with Oh, people are still voting. Sorry, let you guys vote a little more. All right, I think 14 out of 19. We'll take that. Well, thank you all for being here, and I'm going to move on with the presentation. And I want to first ask this question: what does a successful POCUS program look like? What does that even mean? And I think for with all the clients I have worked with personally, and for myself specifically, a successful POCUS program got to do three things. One, it should improve patient care. Two, it should also fit clinically into the workflow, fit well and smoothly into the workflow. And the third part is it should really bring positive ROI, right? You don't want this to be a drain on your finances, especially if you are an independent urgent care operator. Now let's go over how you can get there. So this is a bit of a roadmap overview, and we'll cover these steps in this presentation. The first phase is research phase, followed by preparation, then training and implementation, and finally measuring impact. So in your research phase, you've got to figure out whether POCUS is right for you for your practice, right? So first of all, what problem are you solving? Is this radiology tech shortages that you're dealing with? Is it really hard to get imaging, save for ruling out a DVT in your area because perhaps you're in a rural area? It takes 2 days for you to schedule an ultrasound or maybe longer. Right. So consider those questions and the problem that you're trying to solve. Well, it could also be that you have quite a bit of competitors in your area and you need something to stand out and give more to your patients. And the second part is it right for your patient population and practice? So it does need to have a clinical impact. So think about that before you go ahead with POCUS. And I put practice here because also if you're very much volume based and your providers have 5 minutes per patient, having them do POCUS would be very, very hard, right? So there needs to be um, enough time, enough cushion between the patient visits to be able to do POCUS. So POCUS does take around 5 minutes when you're learning. It takes longer. So make sure your practice can accommodate that. And these are some of the high yield use cases for urgent care and primary care that you can consider while looking at POCUS. So those are your patients with like swelling and pain, where you could be looking for a DVT or maybe CHF exacerbation, patients with soft tissue complaints, looking for abscess or cellulitis or potentially foreign bodies that are not seen on an x-ray. Cough and dyspnea. I know urgent care see a ton of those, but ruling in or ruling out a pneumonia, pneumothorax, CHF, viral illness, and also urinary symptoms, hydronephrosis and urinary retention. We actually have a webinar coming up on June 30th, specifically on renal and bladder ultrasound, if you'd like to join. Abdominal pain, so looking for AAA, looking for ascites, cholelithiasis, choledocholitis, all of that is possible at the bedside with POCUS. Musculoskeletal injuries are really big, right? So you've got fractures that you can evaluate for joint effusions, joint dislocations, tendon tears, tendinopathies, procedural guidance, so performing those INDs, IV insertions, joint aspirations. So there's so much that you can do with POCUS. And when you're looking in this research phase, figure out 2, maximum 3 applications that would really benefit your patient population. And the next part in the research phase is, are your providers on board? You really want to have a buy-in from your providers. Do they believe in the tool or do they need more education on what POCUS can do? The good thing is that a lot of newer providers are now graduating with some POCUS skills. So it is in the curriculums in PA schools, in nursing schools, and also in the medical schools and residencies. So I think there's a lot more familiarity with this tool, but definitely get a buy-in from your providers. Are they willing to dedicate the time to learn the skill? And then in this research phase, also look at the finances. Is it financially viable for your practice? Is it potentially profitable? So consider those overhead costs, the potential profit it can bring, and also your payer contract, super important. So review those insurance contracts. uh, what type of CPT codes are in your insurance already and what is the reimbursement? If you are in a global rate contract, is there a potential to do carve out to introduce POCUS? And some of you might be more into value-based type of care contracts and capitated plans. So what is the overall cost savings? Or maybe meeting certain quality metrics that would lead to revenue for your practice. So this is all in the research phase. And I do want to give you this resource that we have on our website that's free. There's two different calculators. Use the first one for outpatient clinics, but it basically uses 2026 nationwide CMS fees, physician fees, to give you a potential estimate on the reimbursement in more of a fee-for-service structure. So, and it depends on the volume of scans you're doing. And the final stage in this research is what resources do you have available internally? And that really matters for the practices that are affiliated with bigger institutions. In the bigger institution, you might already have a POCUS committee, some POCUS credentialing policies that other departments are using, and you can borrow and edit for your urgent care, primary care clinic. You also want to look what kind of workflows are they using for image storage. What is their quality assurance process? How are they documenting things? Right. So there's so much you can learn from other departments or institution if you have that availability. And also, perhaps there's POCUS trained faculty that you have access to. So I think it's really worth it to explore that if you're one of those clinics that has an affiliation. All right, so for the research phase, to sum it up, you got to look at, is it clinically useful? Are the providers on board? Is it financially viable for your clinic? And what internal resources are available to you? Now, let's move on to the second phase. So say you are getting very positive results and you're ready to move forward with POCUS. Oh, and I forgot to tell you, the research phase probably takes around a month or so to gather all that information. So give yourself enough time. Our next phase is the preparation phase. And the important part about preparation is really having the right people on your team. And that means clinical leadership, operational leadership, but also IT and biomed, and a POCUS champion. Make sure there is someone who is really dedicated to making this POCUS initiative a success, a lead person on your team. But I cannot emphasize enough how important for IT to be on board with this. And then you also want to confirm your learners, right? Are there providers who are really excited to learn this skill? Maybe you can do two different rollouts, one for those who are really wanting to learn it and are ready to go, and then you roll out to the rest later. And also confirm your POCUS applications and stick to 2 to 3 applications in that beginning to make this a success. You also want to think about the devices and the workflow. So what device features are important to you on the types of applications you will be performing? Say if you are performing mostly musculoskeletal ultrasound, maybe some soft tissue, procedural ultrasound, you will need a linear probe, a really good linear probe for superficial scanning. So you can research those type of probes more versus if you're doing multiple body parts, you might need either all-in-one probe, like a handheld, or maybe a card-based system would be more suitable for what you are doing. Also think about the connectivity of the devices, the warranty and support you're getting, the AI features that are part of it, and obviously the cost. Really, and the battery life. So there are lots of different things to research during this time.
Yes, that will be.
Hang on. And I'm going to ask you one more time. Would you guys mind just muting yourself because this is a meeting, not a web? I can't mute you just to make sure we don't have the interruption. Thank you. All right. Um, moving forward, and then another question you got to prepare for or an answer here is how will exams be stored? So if you're planning to make clinical decisions, put this in the medical chart and also bill for it, you've got to store these images compliantly, HIPAA compliant permanent storage. So figure out what you have at hand. Maybe it is a PACS system that you're already using for your x-rays and your urgent care, and you can also store your ultrasound images, or maybe you need a different solution. And there are quite a few third-party options out there, or you might need to just store your images internally, securely on your server. And what's available in your institution already, right? So make sure you take a look at this. And also, is there a preference from IT and biomed already, or operations people in your institution? So the next phase is around compliance and quality. Here, you want to start preparing some protocols related to POCUS. So what will be your credentialing protocol, and infection control, and the QA process. So start thinking of this. And actually, ASAP 2023 guidelines, POCUS guidelines, are really a useful place to start. AFP and AIUM also have similar um, I wouldn't say guidelines, but they have similar uh, documents related to how what you need to uh, have POCUS be rolled out in a compliant way. Another thing to consider is clinical pathways. So, how are your providers going to be using POCUS clinically, right? You don't want every single patient getting POCUS. You want to get patients who really would benefit from POCUS get it uh, and make sure that the POCUS is medically necessary. So having some clear guidelines that are evidence-based would be really helpful. And then, of course, we talked about the secure storage. So make sure you have that set up as well. This is just an example of a DBT protocol that we have also available for download on our website. It's completely free and it's a sample. So you would basically structure it based on the types of resources you have, but this is how POCUS can fit in clinically in an outpatient setting for ruling out a DVT. And also in this preparation, you want to set some timelines for yourself. So typically in our experience, the setup, the implementation process takes about 1 to 3 months, 1 to 2 months of developing protocols, getting them approved, getting the device, getting them connected, getting the workflow set up. It really depends a bit on the size of the institution as well, and how many hoops you got to jump through to get something like this put together. So that's the timeline to consider for just the implementation piece. And then the training piece takes anywhere from 3 months to a year, depending on how many applications the providers are learning, your patient volumes, how excited they are to get all the learning underway and completed. So just give some reasonable deadlines for yourself and your team. And the part where we have on here start billing. So anywhere usually typically takes 6 months to implement and train the first group of people, and then the billing can start after 6 months. So we have covered research, and then we've covered the preparation. So, and here just a recap, you got to gather the right team, confirm the exam types and the learners, pick the devices and the storage solution, design protocols and clinical pathways to support the POCUS use in your practice, and set some reasonable timeline and try your best to stick with it. So that preparation stage takes about 1 to 2 months. Our next piece is really operations heavy, and that's training and implementing. So for the implementation piece, you got to purchase your devices, you got to build your workflow, and also make sure you have a QA process in place and get your protocols approved. And then you've got to train and credential your providers. And just a reminder, provider credentialing, that's an internal process. However, you can use external resources to help to help train your providers and reach those credentialing requirements that you internally create based on the guidelines that exist from medical organizations like ASAP. Typically, provider credentialing consists of didactics. So usually it's some kind of combination of online learning and hands-on training. Supervised scanning, that's when the providers are performing educational exams. So and those could be on volunteers or on the patients, but they are not yet making clinical decisions. So they are actually getting feedback from expert POCUS users to make sure they're doing a good job. They're getting good image quality and their interpretation is on point, and they are integrating it clinically in a way that's evidence-based. And then finally, there should be an assessment piece. So it's either could be a structured Q bank or a certification that they can take, or even OSCE style type of exam where the person gets watched performing an ultrasound to make sure they're doing it well. And of course, you can also use those supervised scans as a way to um, for the providers demonstrate their skill, right? So how well are they performing in those on a scale of 1 to 5? Are most of their scans fours and fives, right? Are they getting mostly true positives on there and true negatives versus false positives and false negatives? So you can have those assessments built into your credentialing pathway. And one more piece here is the maintenance of credentialing. So think about how are your providers going to maintain this credentialing after they get that first part completed? Typically, it consists of some requirements around um, minimum number of scans per year. Usually, it's 10 per application. Some CME that could be incorporated into this requirement. And we did put together also a POCUS billing readiness checklist, which kind of goes over the different parts you want to have in place before you even start billing for POCUS. And usually, basically, you want to have the archiving in place, proper documentation templates, and also your providers trained and credentialed before you start billing for POCUS. And making sure your payer contracts include POCUS as a reimbursable procedure. So here we have covered research and preparation step and also training and implementation. And here we go. So for the implementation work, for the training implementation, you've got to build your workflow. You've got to design those procedure node, get all those protocols approved, credential the providers, start the QA process, and start billing. And that takes anywhere from 3 months to 12 months in a typical practice. And our next step after you start using POCUS is really measuring the impact of the program to see whether it's worthwhile to maintain the program, maybe even expand it or train more providers. So in terms of collecting data, you want to collect data on the utilization, so volume of scans you're doing. You want to look at patient and provider experience with POCUS. That's a really great data to track. Are the patients having a better experience, better trust for the providers? There's actually research showing that, in fact, they do when POCUS is being used. But also from the provider perspective, are the providers feeling more confident in their diagnosis because they are using POCUS for additional data points to make a clinical decision? You can also track your referrals to the EDs or specialists, and then financials, of course, are you getting reimbursed for it? So this is the whole roadmap here. So the first step being research, the second one being preparation, and then you got training and implementation, and finally measuring impact. And to sum up the impact part, so you want to look at patient provider experience, POCUS utilization, ED diversion, and referrals to specialists, looking at your throughput, for example, and the financials of the POCUS program. And that measuring impact is ongoing. And some tips, some things we've learned from working with various organizations and practices is first of all, when you're just starting out, have some strict clinical pathways. So very simple. When we have a patient with low DVT risk, we do POCUS and send a D-dimer, for example. That's what we do for all of our patients. Or maybe we don't send a D-dimer because our D-dimer takes 24 hours or 48 hours to come back, and we are not going to do it. We are doing POCUS only approach, which is also supported by evidence. So just having that clarity with your providers would be really helpful in the beginning. Definitely pilot first. So start small, start with uh, if you are multi-location, urgent care or primary care clinic, maybe start at 1 to 3 clinics initially with the people who are really excited to learn the tool and implement it. And then you can decide if you want to roll it out to more locations and providers. And there are also other options in terms of SIM and teleguidance to, especially if you're in a more rural location or your budget is limited, you can achieve some of those supervised scanning by practicing on SIM models. In my experience, it hasn't been as easy to translate it into clinical practice, but there's definitely evidence that it is possible. And it is a great tool to use. And of course, collect data. We have mentioned that before. So I would say the takeaways from this webinar are first, make sure you do your research on the use cases and the financial viability of the program. Ensure the right team is in place. Very, very important, especially bringing on IT early on, because IT will need to build out that workflow. And then make sure you're training the providers and documenting properly and measuring impact. So I'm pretty much done with the presentation. I have just a few webinars I want to tell you about that we have coming up, and then we'll do a little Q&A. So we do have a webinar coming up. June is, for some reason, very busy with webinars. We have a CHF webinar, CHF in primary care, how you can utilize POCUS protocol to evaluate either diagnose patients with CHF or actually manage patients with CHF in outpatient setting. This is a QR code. We'll also share it in the links and the follow-up email. And as I mentioned already, we have a renal and bladder ultrasound webinar also coming up on June 30th. So please do check those out. Those are very much clinical webinars, not operational.